To Err is Human came out in 1999, and it reported that there was around 98,000 deaths a year in the U.S. caused by medical accidents. Another study by John Jones came out in 2013. It estimated around 440,000 deaths a year due to medical errors. A 2016 study by Johns Hopkins said there was a minimum of 250,000 deaths a year in the U.S. due to medical errors. The international statistics weren't much better. There was a Joint Commission study that looked at serious injuries and fatalities per admissions in hospitals. The U.S. had a 2.9% of injury or fatality. UK was 5 to 10%. Canada was 7.5. New Zealand 12.9. Australia a staggering 16.6, which is basically 1 in 6 people going into an Australian hospital were going to be seriously injured or have a Sentinel event due to a medical error. That's basically Russian roulette. This wave of injury and fatalities is one of the largest causes of death in the world. If we look at global statistics, 3 million people a year die from medical injuries. That is more than health and safety. Occupational deaths is 2.78 million people a year. Of that, 1.2 million is automobile traffic-related accidents for occupational safety. So when we think about the volume of people getting injured or fatalities, Sentinel events related to medical, it's a staggering number that come out of the medical system with injury. And yet, the medical industry hasn't stopped. It hasn't stopped the Sentinel events. The volume of people, the injuries numbers, they're not going down. In some cases, they're going up. So welcome to the Taproot Podcast. This week I'm joined by Marcus Miller, and we are going to be getting into why the medical industry hasn't changed its process for Sentinel events, why it's still seeing these repeat problems and errors. So I think I want to open this up with a little question for us, which is, what are the medical problems that they're dealing with?
Well, there's a lot. I mean, it's a very complex system. The medical institutions. I mean, just think of the complexity. Think about all the departments. Radiology, and all those departments trying to talk to each other at the same time, and keeping up with patients going through each of those departments. Patients come in with all these morbidities. I mean, they're getting seen for a lot of different things. And not all systems talk well. I mean, the software systems in hospitals, it's hard for them to keep up. It's hard for them to be integrated. So there's just so much lost in communication.
So I think the first thing to establish is we know that medicine is a complex system. And when I say complex system, for those listening, there is not a clear linear thing to keep track of. It's not like I dug the hole and the dirt came out and I went down and there was a wire and I could see it and I didn't go further. Like you can see there's a linear path to failure in a lot of industrial safety kind of accidents, right? There was water on the ground, I slipped in the puddle and fell and got hurt. When you look at medicine and medical errors, there's a lot of unknowns happening at once. You think of interactions between different medicines. You think of different things happening on different floors, different facilities, different experts coming in to deal with and troubleshoot problems. Diagnostics is not a simple process.
And things are changing all the time. Like technology is changing, and they have to learn how to operate new machines. New medicines come out all the time. And like you were saying, these medicines interact with each other. You got patient histories. If patients aren't honest with you when they come in, and you can prescribe something that's going to hurt them because you don't know the history really well. I mean, there's so many variables that medical professionals have to deal with. It kind of makes it a little more, I guess, transparent on why we're having the patient harm that we have.
And I want to be very clear at the front of this that this conversation we're having is not going to be about it's not going to be a critique on doctors and nurses.
No.
This is not a problem that you can just tell nurses and doctors that they need to try harder not to injure people. I've never met a medical professional personally that wanted to harm a patient. And just telling them to be more careful, or saying we're going to train our way out of this, or have a slogan and get our way out of this by telling people to be more careful, you're not going to. So I think you have to establish at the beginning of this that we have to look at context. We have to understand that they're dealing with complexity and think about tools and processes that are going to help them in there.
The system improvements, right? So I think our medical industry is a little behind, right? We had the aviation accidents that we have, and they've put in some very good system improvements to help that not happen again. Other industries have adopted these systems that are going to help people perform better. But the medical industry, for a lot of reasons, haven't been as quick to adopt those same systems or strategies.
So I think at this, we want to start with, what are the kinds of things that people might look out for when it comes to medical errors? What are the problems that are occurring? And I found a list that was actually in one of the studies that I had mentioned earlier, the Johns Hopkins study, and they listed out 4 different types of errors that you see in the medical field. So they have errors of commission. That would be like somebody makes a mistake doing something. Errors of omission. That would be an action that wasn't taken that should have been taken, medical action. They had errors of communication. That could be between 2 doctors or nurses communicating, medical professionals communicating information to each other, but it can also be medical professionals communicating to the patient. So it could be things like, aftercare or dosage.
So what I'm hearing there is there's a lot of blame just in those. I mean, that's pointing to the people doing the work that are the problem.
And the last one is errors in context and diagnostic, missing information. And I think when we think of those, and I tie it back to what we know in Taproot, that's a causal factor. And if we just stopped at somebody made a mistake, somebody took an action not taken, somebody got confused by information, and somebody missed information and then made a mistake, if we just stop there, you're exactly right. We're just going to be blaming doctors, blaming nurses.
Well, and we just talked about how complex these systems are. So for medical institutions to recognize that they have a problem, and they look at it, they get smart people in the room, and they talk about, okay, what happened here? Let's track this down. Oh, we found out somebody made a mistake. Now, instead of having like a robust root cause analysis for that mistake, they just go straight into, how do we fix this? And when you're stuck there, you have very limited options. I mean, your only options at that point, well, we can discipline them and make sure everybody knows that this isn't okay. We can try to retrain them and hope they're more careful next time, fully knowing that the training isn't what caused them to make the mistake. It's probably the complexity. It's probably the conditions that they were facing that day, the adversity they were facing that day, doing the best they can, but they made a mistake. There was no systems to back them up, to support them for their performance. Or they add policy and procedures to already unmanageable policies and procedures, right? Just giving people more rules to make the job idiot-proof. And it just doesn't work that way. Those corrective actions are ineffective, but you're stuck with them if you don't analyze these problems that they're finding, these mistakes that people are making.
So I remember hearing a story, and this was a story told by a person who was a travel nurse at the time of the incident. And what had happened to them, as a travel nurse, you're moving between hospitals, between locations, you're filling in. So you're putting a person that has a lot of training and knowledge into a new environment, meaning where things are located is unfamiliar to them. They're typically working a terrible schedule because they're the flex person that goes in to fill in spots. Mm-hmm. So they're typically not working like the best possible sleep schedule. They're typically working the worst ones. And they are typically put in an environment where resources are thin, which is a lot of hospitals these days. And so you've got this travel nurse moving around, and the person was on duty, and they had a patient who needed insulin. And that's a pretty standard thing for people in hospitals, need to give a dose of insulin to a person. So they go, they were toward the end of a night shift. They'd been working a long shift and they're toward the end of it. And they go to quickly do this because they had several things happening. So they had to quickly get this person their dose. And they go in the room, they open the drawer, they grab the dosage needle, they get the amount out, and they give the insulin to the patient. Well, they recognized right after they did that they had grabbed the wrong syringe. And instead of giving an insulin dosage syringe, they had, and I cannot remember the type, it was a different one. Let's just say it was a different volume set. And so instead of giving 5 milliliters or something, they gave a much larger dose of insulin. So instead of giving the standard dose, they gave them 10 times. And so the patient lived, they were monitored, and they had to be closely monitored to make sure there was no adverse condition. But that very easily could have been a fatality.
I guarantee if you ask anybody watching this podcast, anybody that I asked in our courses, if they know somebody that's been affected by medical errors, that could have been really bad or were really bad, everybody has a story. Everybody knows somebody, if it's not them, whose chart got mixed up, a doctor came in and say, hey, we're here to treat you for this. And you're like, no, that's not me, right? And even worse stuff, right, that we're probably not going to get into. But everybody has those stories, which backs up the numbers that you gave at the beginning of this podcast, that how many medical errors are happening all around us.
It's the third, and depending on which numbers you accept for what is the likely, it's not even known, which is probably the scariest number to me, is that the fact that we don't know it's somewhere between 100 and 400,000 deaths a year. That's not an insubstantial.
Well, that goes into another problem too, is just the transparency in the healthcare system. It's so hard to be transparent. Like, I know everybody wants to be, but there's so many reasons that we give medical facilities not to be, right? Number one is probably litigation. Right? Everybody's afraid they're going to get sued. We try to cover things up or try to pay for it to go away, and we don't really learn from these events because we're just trying to get through it.
Yeah, and I think just taking that example that I had, if you looked at that incident and you said, well, it was the nurse's fault, they should have checked that they had the right needle. That's a mindset people come in, and lawyer comes in and says, yep, there it is. The nurse didn't do this check. They were supposed to do this check, they didn't. But if you look at the context of it, you take somebody unfamiliar with your system on a off shift at the end of a long shift, probably a double shift. Let's be honest with the medical industry, they're probably working double shift. And then you put the same the two types of needles just dumped in a drawer. This isn't like an organized, well-made 5S. No, they're dumped in a pile in this drawer. You open it up, you grab one. And they look the same. I put this on there. They look similar. They're not exactly the same. The dosage is different. There's a little change in shape. Could have been noticed, but wasn't when you're in a hurry. And so you're setting someone up for these kind of mistakes as an organization. And if that mistake gets made and it results in something, if your mentality is to come in and say, okay, we need to close ranks, not share information because we don't want to put ourselves, up for litigation. The less I know about this, the better, because then under discovery, I don't know. I don't have any of these details. If they're lost, that's better for our defense,
right?
Which I think is one of the most perverse reasons why we don't have change.
But you can understand why it happens.
Yeah.
Right? So just think of the learning opportunities you're losing to figure out, okay, where was our system weak that allowed this nurse to pick up the wrong? Like, how do we help her not make that mistake again? What systems do we put in place? What tools do we give them to make sure that the people perform better? We just lose all of that. And then the other big reason that we're having these issues, and you mentioned it before, is we just don't have adequate staff. Right? How many people are leaving the profession because they're getting blamed, they're getting burned out for the situations that they're in? So people make mistakes. Instead of looking at the conditions or the adversity they're facing when they're making the mistake, we're trying to fix it by fixing the person through those other corrective actions. we lose all that opportunity to learn from these mistakes because we're pushing through them.
And you mentioned this burnout thing. If you think about the stress that you're putting somebody under by having them in a situation where they are the final safeguard for everything, and you've got to always be perfect, always be checking, triple checking, and you're the safeguard, well, you're putting a person under a lot of stress and setting them up for failure at the same time. We know people are not reliable safeguards.
It's making it worse.
It
right.
is.
And that leads me, it's one thing I tell everybody that I know when they go into any type of medical facility, don't be your own best safeguard, right? Always bring a loved one with you, somebody from your family, somebody that's not afraid to question authority, right? Because you've got to slow down the healthcare professionals because, like we're saying, they're overworked, they're overwhelmed. Somebody has to ask them questions, slow them down so their brain gets focused on you, not the next patient that they're not going to see, not here's the next thing on my schedule, but slow them down, ask questions, and that helps them focus, get back into the moment. So it makes it less likely they're going to make mistakes. But your best safeguard is your loved one. I don't think you can depend on the safeguards that are in place there because there's not a lot that are going to prevent people from making mistakes.
And, I have a family member who, they're retired now, but they were a nurse and they were a nurse manager as well. And so if we have somebody in the hospital, we're calling that person up. Mostly because it'll help make sure that we're asking the right questions and giving the right information to our doctors and to our nurses and the people taking care. And it's always been a benefit when you have somebody with that experience in your family to be able to reach out, because we know that we're entering a place where a lot of safeguards are not put in place. Now, I'll push this to I think a philosophy thing, and one of the types of accidents that I think is super preventable is MRI accidents. And the accidents that I'm talking about for an MRI, and for those that don't know, you've got a giant magnet in an MRI, and if any metal gets near it, it is flying at that magnet. It's not a small thing. It's a great force, and it can kill you. And in fact, one of the earliest MRI accidents was in 2001. There was Michael Colomboni. He was a 6-year-old. They were going in for a routine MRI follow-up after having a brain tumor removed. So you're talking about a very young child dealing with a very scary situation. So he goes to have this MRI. To do that, you've got an anesthetist that's going to come in and basically put them to sleep while they do the MRI because you can't move. So sleep, strapped in, all that. And while they were doing this, the oxygen supply messed up in the room. So you've got a kid who just had brain surgery and there's an oxygen problem. So the people, the staff at the time, they go and try to get an alternate oxygen supply. Well, right outside of the room is the prep room, and in there was a metal oxygen canister. And so they quickly grab that and head back into the room, and that metal canister is pulled out of their hand and ends up killing the 6-year-old. And that's a tragic event, and that was 2001. You'd think something like that would be a wake-up change call for the industry. And you see that if you go look at, you could find news reports of this. There's tons of people saying, oh, we're going to change this, we're going to do all these. In 2025, there was another story, this was in the Bahamas, of a man who he died after his wife was getting the MRI, and he was allowed to come into the room to help her off the table. He was wearing a chain around his neck, and it pulled him in and killed him on the MRI machine.
Jeez.
And you think about these kind of things, it's like, this is a known issue. What are the corrective actions? What are the things that are recommended? What are the standards? Well, if you look at the standards, medical professionals screen people before entering. So I give them a form. It says, don't bring anything metal in there. And I check them and say, do you got any metal in your pockets? I feel like it's the airport security, right? Do you have you removed your belt? Do you have any jewelry? Is there anything in your pockets? They do that. They have a sign that says the magnet is always on. There's special MRI compatible equipment that's used in the area. You have training and drills that keep the people that are staffed in there aware of the hazards. And you have ferromagnetic detection equipment, but that's not required, that's recommended. And so you think, okay, if you look at safeguard hierarchy, having a person check, that's at the bottom. Signs, that's at the bottom. Training, that's at the bottom. Ferromagnetic detection device, well, that's pretty good, not required. Sometimes they use wands. Sometimes they have like the little giant ones you do when you're going into the courthouse or something. But it's inconsistent across the industry, and you still see those. There was a case of, and I think this was in India, they had a ferro detection device, but it was broken and they hadn't fixed it. And so they had left it broken for a long period of time.
And plus, people are probably used to that safeguard. So
now they're comfortable.
They're comfortable and a little lax, and they have their own habits. And now that's not available. The people probably don't perform well. And so, I can guess where this is going.
You know, and we just think about that. Even the Michael, the first case with the 6-year-old, you know, they had the right equipment in the room, but they had ferromagnetic equipment right outside of it. So in an emergency, they go out. Now they've got all this ferromagnetic materials and stuff that if it was brought into the room could have that problem. Yeah. And so you see mistakes like that occur far too frequently for MRIs. And why are they not fixing it? I think it starts with poor investigations. And what's the most common, you know, type of investigation in medical? Well, one, it's probably not investigating like we talked about earlier, but I think also they use a lot of 5 whys because it's simple, easy to train, and we don't have to spend a huge amount of money training people on it. And I think that's one of the biggest mistakes that's in here as far as what investigations they're doing is they're not doing ones that help better understand the system in context. A lot of times when you have a bias-based system, it's easy to stop at somebody made a mistake, tell them to do better next time. They need to have a system that's helping lay out the process, what happened, and the context behind it. So I think one of the more personal examples to us was the Redonda VOT case, and you were able to walk through that. Can you kind of tell the experience of walking through that snap chart?
It was really eye-opening for me too, as well as Redonda. She actually told me until we put this together, like she does still and will always feel guilt for her mistake. But when we lined out the sequence of events and started asking questions about those events, and then started looking at the safeguards that are in place, we saw, I think it was 9 different safeguards fail at the same time she made her mistake that allowed that patient to lose their life. 9 different safeguards that failed. I mean, that's incredible. So when she saw that, she was like, oh, I'm not solely responsible. And that kind of helped her get past that guilt and despair and get her into a position where she's like, well, we can't have our healthcare workers working in conditions where these other safeguards can fail, and it's all on us to keep patients alive. And she kind of used that as a springboard to get involved with creating or at least talking to the legislators about putting laws in place to protect healthcare workers so we don't lose so many healthcare workers because of burnout, fatigue, and them just being punished for simple mistakes. So it turned in, as positive as it could for Redonda. I think she's still speaking and helping other people become aware that, healthcare workers face a huge challenge, and trying to find ways to help hospital systems understand how to really analyze the mistakes people are making so they can recognize where they can improve the systems in the hospital to help people perform better. So it's not the person who's the last line of defense on keeping patients alive.
And I know a lot of nurses that, and they'll say it straight to you of oh no, it was her fault. And they do that because she did make a mistake. She made not just one, she made multiple. And when we recognize that we have to take this step back and say, yes, a person made a mistake, but look at these safeguards that failed, that enabled that mistake, that contributed to it, that set them up for success or failure. How many medical professionals are being set up for failure by systems that are being ill-maintained, that are being rushed out before they're actually working, or a lot of the times, and in her case, they had a known system problem that they were just okay dealing with every day. They accepted, yes, this was a problem. You just bypass it this way, and that's
until we get it fixed.
We'll get it fixed. There's no estimation on when that will happen, but it'll get fixed.
Because everybody's busy. I mean, it's like a vicious cycle. There's so much going on. We're trying to take care of these patients. It doesn't stop, and there's no like downtime to say, okay, let's go back and look at this problem that we had before. No, it's just continue on because we have to. Because there's no systems in place to really analyze and fix things. And if we could do that, well, then we'd have a lot less emergencies or some fires to put out, because the systems are doing what they're designed to do, is helping people perform better, not make the mistakes. Or if they do make a mistake, the system's going to catch it. Something's going to catch it before somebody gets harmed.
So if we look at Taproot, why we approach investigations this way, that snap chart really helps you picture it, lay it out, and understand. It's a timeline of events, and it's events where you add context to understand the decisions that were made, the systems that were in place, and the facts and evidence that guide the investigation.
Well, it lays out all the conditions, all the adversity that person was facing at that specific moment when they made the mistake. That's what people miss when they start just talking about mistakes that people make. We've got to look at the adversity, the conditions that they were faced with at the time. Instead of blaming them, put yourself in their shoes. Here's what's going on. And when you do that, the blame starts to shift away from the person, and people start to realize, well, if I was in that situation, I probably would have done the same thing. But instead of doing that, we say, oh, well, it was their fault, so let's retrade them. Or let's get, regulatory agencies involved, and people lose their licenses or their ability to practice medicine because we never really understood why they made the mistake in the first place. We just blamed them for it.
So if we step back and say, okay, we're doing better investigations. If I also look at things in the medical industry, I look at corrective actions, and you look at what kind of actions are being put in place after an incident. There's been cases of really good corrective actions in medicine and really poor corrective actions. So thinking of like, what's an example of a really good corrective action that I'm aware of? One of the issues that people were having is they have lots of different airlines. You've got process air, you've got oxygen, you might have a neutralizing air. There's lots of different types of air hoses that could be hooked up. And an easy error that can be made is I plug the wrong hose into the wrong air system. And now what I think is oxygen might be some other air system that I'm plugging in. And so one of the ways that some hospitals have developed to prevent that is by giving each air system its own color and its own connector type. So it's just like when you can't travel overseas with the same plug in for your, charging cable. Everybody's got their own standard. These all have different plugs. So I can't put the oxygen in the compressed air line. I can't plug them into the wrong one. Those are the kind of corrective actions that are preventing mistake.
And it's hard to do, I understand, but those are the type of corrective actions that, if they were standardized, would prevent a lot of other people from getting hurt from the same reasons, right? Yeah. But it's not. It's not standardized throughout the industry. Maybe in just one hospital system, the hospital system that had something bad happen and realized how important it is to do something like that. And we're going to have to wait for the other hospital systems to have something really bad happen, so they understand how important it is to do that.
And you're hoping that not only that, but that they recognize the best practice they could be putting in place. So because you have hospital systems that are so distributed, so localized, and so locally managed, those best practices often don't get shared. And so, I've been to facilities that had really good layouts and 5S and good systems for separating. And I've been to ones that were, I was questioning my own safety for every drawer that was opened looked like a nightmare. And so you kind of think of the differences in facilities and standardization. Abilities to share best practices is, I think, critical in that industry. The other thing is when we think about corrective actions for when somebody makes a mistake. A lot of times you'll see the same 3 corrective actions. You'll see disciplining the person involved. And in the medical industry, that might be revoking their license, that might be putting them on leave, that might be all sorts of transferring them to a different area, different unit. You also have things like retraining. And if you're just doing the same training they had, or you're just having them sign something about a policy, or this is the process, it doesn't last, and it's not a good corrective action. Telling people to be more careful does not prevent problems. It's not a good solution. Adding another check is okay, but it's not going to be that effective. You have to recognize that what you need to be doing for corrective actions is looking at how you can make it easy to do the right thing, hard to do the wrong thing from a human performance standpoint.
Yeah, that's true. And when people are making mistakes, I know even if you discipline them, if you retrain them, in the back of their mind, they're like, I know I didn't do this because I wasn't trained well, or I knew I didn't make this mistake because I'm a bad person or I tried to hurt somebody. It doesn't make sense to them. And when you have that situation, your culture is going to suffer, right? Because all your workers are going to be, it's going to be so blame oriented. They're going to, anytime you do an investigation, they're not going to give you information because they feel like they're going to get blamed. And one of those corrective actions are going to apply to them. So the transparency goes out the window. Right? So those type of corrective actions they're not only ineffective, they hurt your culture because people they know that wasn't why they made the mistake. But nobody cared enough to really understand the situation they were in to truly analyze it and find out how do we fix these holes in our systems to better support the health. If we could do that, if healthcare workers saw that, things get better when I self-report or when I make a mistake, you think they're going to be a little more transparent and give you the information you need to really analyze the situation? Because they see everything that they're doing to help you investigate is going to lead to them being better supported, which leads to patients not getting harmed.
And if you look at like doctors and nurses, they, at least in the US, they go into substantial debt because it takes years to make a good medical professional that has the knowledge and skills needed to actually treat people effectively. And so if you're constantly afraid that you're going to lose your job, and therefore all of this effort and debt that you've accrued in order to get the skills needed to do the job, I mean, there's such an incentive to hide any mistake.
Plus, think about the people that are really good at it. Like anytime you've been to the hospital and were taken care of, you probably have 2 or 3 nurses or healthcare professionals that are like, they were really good. I could tell they cared. Those are the first people that get burnt out and leave the profession because they're there for altruistic reasons. They want to help people. And when the bureaucracy, when blame happens, they're the first people out the door because they're not there just for a paycheck, right? They leave. And that hurts the industry. And again, a vicious cycle because now we have less healthcare workers. That puts the ones that are left in worse situations, and that's more likely to help them make mistakes.
Now, the fourth kind of reason why there has not been an improvement in this is really on the, we'll say the management and billing side of this.
For sure.
So what are some problems that we deal with in healthcare? How does the insurance and management of hospitals lead to no change in patient outcomes?
The first one I always hear is we've got to do more with less, right? So a lot of the reimbursement systems set on how many procedures you can do, not on the quality of the procedures that you do, right? So for hospitals to be financially stable, they've got to get these procedures done, right? And so if you're focused on how efficient can we be, how much can we make these doctors do, how much can we make these nurses do, how many patients can, even as simple as a care tech, how many patients can they take care of on a shift, how many do we really need? So that reimbursement drives a lot of this.
And if you think about we know that the medical industry is relatively short-staffed. We don't have enough nurses. We don't have enough doctors. That's even worse when you look at other countries as well. I can't remember what the study was in the UK, but it was like, the amount of time it took to see your primary care doctor, not a hospital, but just a primary care doctor was months and months just to get in the door to see them. And it's just because they don't have the staffing levels. So if you don't have the staffing levels, what that leads to is crazy shift schedules that are putting people fatigued. I know a lot of 24 hours, I'm on for 24, I'm on for this, and they just assume you're going to nap during this shift and sleep, and you're going to get good sleep, right? Because you're in a hospital, you're not going to get woken up and bothered, right, for sleep. So you're putting people that are having to make complex decisions and making off of very limited knowledge, and then you're also saying, okay, let's also sleep deprive them. Mm-hmm. That will help make improvements on this and sleep deprive them as well. So I think hospital administrator decisions can often affect whether or not an organization is going to learn. I know from our standpoint, we have worked with hospitals that have struggled to do implementation of good RCA because they struggle to get the budget for it, because they we could spend money on training people to do this investigation, or I could buy this new piece of equipment that I can bill for. What would I do? What's going to be, where do I want to spend my budget? And a lot of the times the idea of we can get more billable hours out of this equipment as opposed to training people in an appropriate way.
True, and I also think, and I've seen, in hospitals when they have these Sentinel events or patient harm, they have people assigned to investigate, but they don't have proper training to do that. And it's just a piece of their job, right? Yeah. So they already are overworked, and now they've got to do this. So it's just almost like we got to get through this. We got to get this off our plate because we got other patients that need our help. Now, I've seen some hospital systems, they're starting to catch up where they'll go out and they'll hire a professional safety person from oil and gas or the airline industry to come in and focus on helping them really truly investigate, find the real underlying issues that need to be fixed, and help the hospitals fix systems. And that goes a lot better than putting people that are just a piece of their job as to investigate and to put in corrective actions. It works a lot better than just relying on those guys to do it, because they've got so many other responsibilities.
Yeah, and I mean, if you look at something like a surgeon or a doctor's time, getting them in the room to go through an investigation, a thorough investigation, can be difficult because, again, like you said, they've got patients to see, they've got people that need their care, and taking time to learn is a difficult challenge in that industry. And so that takes a leadership mindset of, hey, we have to put patient safety and patient care at the forefront of our values.
And we have to get professionals that know how to use a robust analyzing system, not just let's get in the room and talk about it and figure out where things went wrong and go straight into fixes.
Yeah.
We do need to sit down. We need to talk about it. We need to investigate and find out what went wrong, who made a mistake. But that whole piece of analyzing the underlying conditions and using that to find root causes, instead of just putting Band-Aids on the symptoms that they see, that the mistakes are symptoms of those root causes. So they're just fixing symptoms, right? They never fix I shouldn't say never, but they don't fix the underlying reasons. And that's why they keep having these repeat Sentinel events or patient harm, because they just don't dig deep enough.
So if the medical industry wants to make change, they need to recognize that they are setting people up. This is not a human error problem. This is a systems problem where we're setting people up for failure. They need to do a better job of understanding what happened, gathering information, and finding real human performance root causes that they can control. They need to create stronger corrective actions and getting away from just discipline and training employees. And they need to really have a leadership values focus where they're saying patient care, patient safety is a top priority for us. And because we actually care about it, we're going to put the resources needed to understand the gaps in our current system so that we can close them and improve patient outcome and patient care.
I think it's the first thing they have control of. Like, you're not going to change the reimbursement system overnight, right? All the other the staff shortages, that's not going to change overnight. But what they can change, what they have control of, is making sure that they have a team that can do exactly what you said, can investigate well, understand the adversity, the conditions people face when they make the mistakes, and have a robust system to take that information, analyze it for system weaknesses or root causes, and have somebody trained in how do we put together these corrective actions to fill these holes in our systems so people are better supported.
Now,
that's what they can do.
If a hospital or medical network wants to learn more about root cause analysis, what do we have available for them?
So we do have a patient safety taproot course where anybody who goes through that's going to be able to use the taproot RCA tools. They'll be able to use their investigation skills to build a snap chart to truly understand what happened. They'll have the skills to identify, okay, here's where our problems, here are our causal factors. If we can get rid of these, then we don't have to worry about this incident happening again. Once they identify those causal factors, we'll teach them how to use the root cause tree and dictionary, a standardized way to analyze that evidence that you collected, those conditions. And then once you find your root causes, we've got a corrective action helper that they don't have to start from scratch. If root causes are just the absence of best practice or building systems, we've got ideas on how to build those systems, how to fill in those holes that they can use to create their own corrective actions. And then we also teach them how to make sure that you can prove that these corrective actions are effective, right? Not just put them in place and hope they work, get on to the next fire, and then have a repeat incident where everybody's frustrated because we thought we already fixed this. But we truly will show them how you go back and prove to management, regulatory agencies that what we've done are preventing these mistakes from happening again.
All right. So if you want to get that information, you can find out information down below going to our website, taproot.com. Under courses, we'll post the link for the patient safety course. You can find there to reach out to contact us. We come on site to do these.
And if you want more detail and understanding the process and the RCA tools, they can always request a briefing where we can get on a webinar for an hour and take you through the process to help you evaluate if this is the right decision for you.
So follow the links down below to find out more, and we will see you at the next Taproot podcast.